Um, all of you know who I am, so I'm not going to spend time introducing myself. That's who I am. I'm from the Division of Pediatric Nephrology. Why was I interested in giving this talk? Because I've been asked by many people whether or not giving saline to a child, baby, adult would be harmful because of all these different sort of controversies and different solutions, some of them called balanced solutions and so on and so forth, have been introduced into the literature. And there are some very strong camps about what needs to be done. So I thought it's best to sort of approach it from the point of view of practicality. What would we do if we saw a patient? So these are our objectives. So first of all, I want to take you through the understanding of what saline infusion can or will not do to acid-base status in the blood, and then try to figure out what the etiology, if there is an acid-base disturbance, and whether or not there are any potential complications associated with it, so we should be aware of, and therefore maybe in certain circumstances or in all circumstances not use normal saline. So with that in mind, I have your first iClicker question. So normal saline infusion in large volume results in A, metabolic acidosis, B, clinically relevant acid-base changes, C, no change in acid-base levels that I have noticed. Please select one of the three. It's not a trick question. It's just for me to get an understanding of what your thoughts are. So 68%, I'm just going to write these down because I'm going to come back to it afterwards. So 68% think that metabolic acidosis results after you have had large volume of saline infusion. And some of you are honest enough to say that you haven't really noticed any changes. So our next question is, why am I not going back? All right, so my second question to you is, if you did develop metabolic acidosis after someone has had large volume of saline infusion, what is it due to? So you have your choices. Please make your selections. Okay, so now we have a smattering of answers. Some of you think that it may be dilution of bicarbonate, but most of you seem to think that it's because of chloride in excess of sodium. And I'm really glad to see that a third of you said that you don't know, which is good to know. Okay. So now I have a question for you with the patient. So this is sort of a typical question that I sometimes get asked. And so here's a baby, excuse me, who presents at 1 year of age to the emergency room with a history of diarrhea. So there is your blood work. So this is just regular plasma, right, from your, not a gas, that's what I'm trying to say. So there's your sodium, there's your chloride, there's your TCO2, which is bicarbonate, and the anion gap. So what is the acid-base disorder? Go ahead and select. All right. So very good. Most of you think that this is normal anion gap metabolic acidosis based on the fact that the anion gap is normal. And some of you are saying that you won't be able to comment without the pH. I'm so sorry. We'll get back to it in a minute about whether or not you need to have the pH to be able to say whether somebody's got metabolic acidosis. Okay, so now the same baby has received 40 mils per kilogram normal saline, so it's a fair amount fairly quickly. So what is the acid-base disorder now? So now is the levels that are at the top. That's that. So now this is a venous gas. So what do you think is going on now? Please make your selections. Okay. So it's still normal anion gap metabolic acidosis, and about 8% of you chose that you cannot comment without an albumin level. So that's, again, interesting. So blood work is done again in 3 hours with continued normal saline infusion with maintenance plus whatever the dehydration level is supposed to be, and so it's, fairly large volume is running. So now we have, this is our new blood work. So what do you think is going on now? Is the acidosis getting worse? Should we give more fluid because perfusion is poor? Do we think that lactate level is high, or none of the above? Okay, so we have none of the above as the main answer, but we do have A, acidosis is getting worse, and then we have B and C that probably 1% chose. Okay. So there is a decrease in bicarbonate, right? We saw that. So when we get bicarbonate decrease, there is dilution of bicarbonate with large NS infusion, or there may also be addition of large amounts of chloride, which could have caused hyperchloremic metabolic acidosis. There could be ongoing diarrheal loss of bicarbonate, none of the above, all of the above. So I want you to choose again. Okay, very good. I don't have to talk anymore. All right, so there is this big proposition in the literature about dilutional acidosis. There is a lot of controversy about it with regards to whether or not it is real, whether this happens only in vitro, so that means outside the body and not inside the body because of various changes that happen between interstitial fluid and plasma fluid. However, there are certain groups of studies that have been done in animals as well as in humans showing that there is a possibility of dilutional acidosis. So like I said, there are groups of people who will say there is no such thing as dilutional acidosis. In fact, there are editorials written about it saying that dilutional acidosis is the delusion of whoever that's talking about it. So people have very strong opinions about it. But in simply put terms, we do see dilutional acidosis as well as the opposite, contraction alkalosis, and that's just on the basis of what I've shown you here. So if you have bicarbonate in 5 liters of blood as 25 millimoles per liter, that's the concentration. And now if you expanded that volume by to 10 liters or twice as much, the bicarbonate concentration is going to fall by 50%. That's just pure math. It doesn't happen exactly like that, but similar to this sort of decrease, you will see some amount of decrease because of dilution. But remember, the body is not a full box. As you're giving the fluid, there is also the wonderful kidneys that are excreting all these things. So it doesn't really reach steady state, and it's dynamic, and therefore it's not completely all dilutional if you're going to explain acidosis as a result of giving somebody normal saline on the basis of dilution. What about this hyperchloremic acidosis? So as I put up there, plasma has a sodium concentration around 140 and chloride around 105 or 100 to 109. Normal saline, by virtue of how it is mixed together, has got equimolar amounts of sodium and chloride. So the sodium is 154 and chloride is 154. And because you put this sodium chloride solution, which is higher in chloride concentration than plasma, into the plasma, the chloride concentration naturally goes up in the plasma. Does that make sense? So what happens to the sodium? Why doesn't the sodium go up? Sodium doesn't go up as much, or very little, because of the osmotic coefficient of sodium. So when sodium is put in a tank of free water, it's going to be 154 millimoles per liter. That's what you prepared. When you put it into the blood, because of other sort of liquid phases that are not quite within the free water phase of the ECF volume, it's going to be about 0.92. So if you multiply 154 by 0.92, you'll get an answer of about 141, 142. So that's why the sodium concentration, when you add normal saline to the plasma, doesn't go up as much. However, chloride is going to go up because the discrepancy for chloride is much, much higher, right, from 100 to 154. Question is, where are the protons coming from if you had hyperchloremic acidosis? Notice that I haven't said metabolic acidosis. So the addition of chloride is felt to cause the water component of blood to dissociate to produce the hydrogen ion. Because now you have increased the amount of chloride in the blood, and therefore that has to be counteracted by a cation, and the cation is going to come from water dissociation, and you get hydrogen ion. So this is the theory behind hypochloremic acidosis that is associated with normal saline infusion. And I'll come back to that in a minute after. So first of all, how do we determine if there is metabolic acidosis, right? I mean, that's the biggest question. Do we have metabolic acidosis, first of all? And you'll be surprised that there are so many discrepancies in the ways in which we assess for metabolic acidosis. So the traditional method, or the physiological method that we all used to, is the Henderson-Hasselbalch or modified Henderson-Hasselbalch equation. And I'll show you in the next slide what that means. But there are also two other methods by which acidosis in the blood is assessed. So one is called the base excess, and if you have been in ICU, you know that that's what most of the intensivists will use for whatever reason. But anyway, the other method is the Stewart method, or called the physicochemical method. And that's called the modern method because it was introduced in the late 70s and kind of caught on in the late 80s, and now it has become the norm, particularly in the UK and some parts of Europe and some parts of US as well. Not so much in Canada. Interestingly, the person who proposed this is a Canadian physiologist, but Canada hasn't got on. So what do I mean by physiologic method? So in the physiological method, we use the Henderson-Hasselbalch equation, as I said. So we have hydrogen ion concentration that's equal to a constant after you resolve for the pK of the solution. So it's 24 for the bicarbonate CO2 mix times PCO2 divided by bicarbonate concentration. So therefore, if the pH is low, which means the hydrogen ion concentration is high, and if the bicarbonate is low, then automatically we say that the patient has got metabolic acidosis. So in your previous question, I asked you the question about whether or not you can say someone has got acidosis without looking at the pH, and for the most part, yes, you can, unless there is a problem with PCO2. If you assume that the PCO2 is normal, that there is no compensation by the bicarbonate, if you look at just the bicarbonate, with the history that I gave you about that patient, you really didn't need the pH to be able to say this child had metabolic acidosis. What is this base excess or deficit method? The reason why it's a little bit confusing is that initially when it was proposed, it was proposed as base excess. And then people realized that that was confusing everybody. Then they introduced the term deficit. But whatever the connotation to it is, what they're talking about is base. So what that means is that because in our previous equation with the physiological method, we talked about CO2 and bicarbonate, this method is trying to pull out the CO2 out of the equation so that it can independently assess for metabolic acidosis. Why is that important? That's important in patients that are in the ICU, because these patients are on a ventilator for the most part. Otherwise, they wouldn't get into the ICU, in our ICU anyway. And so they're controlled. The CO2 is controlled. So we want to know what their metabolic status is. Why is that important? Metabolic status assessment is important because it tells us about tissue perfusion, and to some extent it also correlates with outcome, morbidity, length of stay in ICU, and so on and so forth. So therefore, the intensivists are very interested in knowing what the actual metabolic derangement is without having to think about the CO2, because they're controlling for it already. But what they don't realize is that this base excess is only good in acute situation, and I'll show you in the next slide what I mean by that. So what some very clever people did was they took the blood out of the body and they said, okay, if I expose this blood to a PCO2 of 40 to maintain a pH of 7.4, which is normal in the blood, how much base do I have to add or take away from this blood? So that's what base excess is. Base excess means the amount that you have to add, and base excess is the amount that you have to take away. See, I got confused. Base deficit is the amount that you have to add. Okay? So that's what we are looking at. So if you're using, whether it is base excess or base deficit, what you have to look for is the amount that's needed to be either added or taken out to keep this patient in normal pH. But very quickly, it became obvious that even though in outside situations, so in vitro situation, base excess should be 0, it's not always the case. And why is that? Because changes in PCO2 in a patient is different from changes in PCO2 in a test tube lab or into a test tube that you're pumping in. Because now you've got blood and interstitial fluid talking to each other and saying, oh, your PCO2 is going up in the interstitium, therefore I'm going to hold on to some bicarbonate. Or my PCO2 is going down in the interstitium, therefore I'm going to pull some bicarbonate, or whatever. So this is called the push and pull phenomenon. And because of that phenomenon, you have to realize that it's not going to be the exact same as what's outside the body. So why does that happen? That's because we have got ability to buffer the bicarbonate with other, buffer the hydrogen with other anions. The biggest anion that we have to buffer this is hemoglobin. So therefore, when you look at hemoglobin and adjust it to how much fluid this whole plasma will be actually talking to, would be the whole ECF volume. And because the ratio between ECF and plasma volume is 3:1, interstitial volume to plasma volume is 3:1, they decided that they were going to take the hemoglobin as 5 or 50 grams per liter, 5 grams per deciliter, for a normal hemoglobin of 150, so that's 1/3, dilute it down, now add this, so do all this mixture, and now we don't have to do any of these things because these are all programmed into our blood gas machine, and therefore this is called standardized base excess or standardized base deficit, so SBE. That is what we get now. So as you can see, if the base excess is negative or base deficit is positive, then there is metabolic acidosis. But it's not as simple as that, because only if it's an acute problem. Why is that? Can any of you hazard an answer why it'll only apply if it's an acute problem? Hello, kidneys, right? Because kidneys are going to make an adjustment. And so when they make an adjustment, it's going to reflect in your base deficit or base excess, because if you have chronic situation of high acid level in the blood, kidneys are going to retain bicarbonate and make new bicarbonate if they are functioning normally, if we haven't put them in acute kidney injury or failure. The second problem is that if you have edema status, like in a patient with sepsis or heart failure or what have you, and most of us know in the ICU, lots of babies can be quite, 3-4 times bigger in their interstitial volume compared to what they come in. And if that's the case, your initial assumption of the plasma volume being 1/3 of the whole ECF, or relationship of plasma volume to interstitial volume of 1 to 3, is not going to hold true. Therefore, your base excess calculation is going to be wrong. But the machine doesn't know that. That's why machines can never replace us. So having said that, with all of those caveats, they're still easy to use, and we continue to use them. And once we look at that, we shouldn't stop there, because after that we have to say, what is the cause of this acidosis? So we have to look at the pathophysiology, and most of you know anion gap. So in both the base excess method and in the physiologic method, we look at the anion gap, which means that we have got all these cations, sodium plus K, but for the most part we only calculate sodium. And then we have the bicarbonate and chloride, which is a measured anion and measured cation. So there is a normal anion gap of around 12 plus or minus 2. So this discrepancy is called the unmeasured anion, so anion gap. And as you know, for electrical neutrality, otherwise blood is going to spark, we are going to have something that's in there. And for the most part, that's produced by proteins, mainly albumins. So what's the problem there? The anion gap from the protein load is going to come from, like I said, albumin. 75% is due to albumin. And therefore, if you don't look at the albumin level of the blood, you're not going to be able to say whether this anion gap is normal for this patient or not. So having done different studies and looked at human studies as well as animal studies, this seems to be the change that happens when you have a change in albumin. So if you assume your normal albumin level to be 40 grams per liter, for every 10 grams drop in albumin, the anion gap is going to drop by 2.5 millimoles per liter. So for example, if somebody had an albumin of 20 instead of 40, their anion gap, instead of being 12 plus or minus 2, is going to be 7 plus or minus 2. Then to throw into that, the lab has its own variation. So if you look at our lab, the normal is reported as 4 to 16. Why do you think that is? Because these are done out of so-called epidemiologic studies or normal lab variations. And so when they do that, they don't know what the status of the patient's albumin is. They don't know what the status of the patient's intravascular volume is, because if you're a little bit dry, your albumin concentration changes to increase your anion gap so that you can pull more sodium from interstitial fluid. And so there are all these changes, and because of that you get this wide range in anion gap, which makes it useless for you to use unless you can sort of sit down with it and think about it and say, okay, what's going on here? So for the most part, I would say if somebody had got normal albumin levels, and if the ECF volume appears to be not too bad, not too dry, not too wet, then you should use 12 plus or minus 2. Okay? So now we come to the most confusing part of this whole approach, which is the Stewart method. So this is called the physicochemical method. So what Stewart did was, he's a physiologist and a chemist, so he decided that, you know what, enough of all this caveats and this and that and albumin and PCO2 and bicarbonate, and they're all talking to each other, so how can we say somebody's got acidosis as a result of some metabolic derangement? So he decided to look at it in a different way, and he said there are 3 independent variables which have an effect on plasma pH, because he was only going to concentrate on pH, not the bicarbonate. And he said PCO2 definitely has an influence, so hooray to the respirologists. But we are going to leave the nephrologists out, and we are going to talk about strong ion difference. And we are also going to talk about the weak acids, which is mainly made up of proteins and phosphates. So in a series of experiments, by deriving almost 6 different equations, he came up with an idea of strong ion difference and strong ion gap, which is similar to anion gap. The reason why I'm saying all this is because a lot of people still talk about this and also will apply these principles to someone who has had normal saline infusion and has apparent metabolic acidosis. So as you can see, this is going to include all the strong ions and all the strong anions. And so it includes calcium and magnesium as well as sulfates and organic anions, so such as lactate, keto acids, whatever. And the strong ion gap is going to be the gap between the strong ion difference, which is measured and calculated. So it's very confusing. Unless you had a computer program that spits out all this information to you at the bedside, this is going to be very difficult to do. So I'll try to take you through that. So it's called apparent strong ion difference because people decided that they were going to modify original Stewart formula. So we have the cations that we're going to measure, we have the anions that we're going to measure, and therefore there is a strong ion difference of about positive 40. Okay? So the strong positive ions are going to outnumber the strong anions, and you get positive 40. Now, if you were to make a change without any change to the cation side of the equation, but only added chloride so that you increase the chloride by 10 from chloride 105 to 115, you would have reduced the SID to plus 30. So this is what they're talking about when they say hyperchloremic metabolic acidosis, because this chloride addition therefore had to invoke hydrogen production from the blood, and that is the acidosis that you're seeing. So there is always this question of, is this real? So now let's go back to our patient. So we repeated the blood work in 3 hours with continued normal saline infusion. Let me ask you again, what is true about these labs? Is the acidosis getting worse? Would we give more fluid as perfusion is poor? Is lactate level high? None of the above. If you have listened and you haven't fallen asleep, I haven't seen anyone fall asleep, you'd be able to answer now. All right. Some of you still think that there is an increase in acidosis. Some of you still think that you need to give more fluid. Okay, so I haven't made an impression. Okay, so let's just look at it. Okay, can you get that? Okay, let's just look at it. So here we have a venous pH, right, which went from 7.09 to 7.14. What about acidemia then? Is the acidemia getting worse? No, if anything, acidemia is improving, right? You could say part of that is because of the PCO2. So let's look at the bicarbonate. Bicarbonate dropped from 11 to 8.8. Could we explain this on the basis of dilution? Possibly. If you want to sit down and do a calculation, you could. Let's look at the base excess. So the base excess usually tells us that there is some metabolic process that's going on that most likely is as a result of lactate. Right? Daniel? Yes? Perfusion, that's what we're thinking about. So the base excess has changed, if anything, by 1. So what's the next thing that we need to look at? If you are thinking about this is because of poor perfusion, and therefore we need to give this patient more fluid, what are we worried about? We're worried about lactate. What would lactate do to your anion gap? It will raise it. What has happened to anion gap here? It's gone from 4 to 3, so barely any change. So would you give this patient more fluid as perfusion is poor? I want to hear a resounding no. Right? We're not going to do that. Is acidosis getting worse? Probably not, but in a true theoretical sense, you could say the bicarbonate concentration has fallen, even though pH has improved. That may be an effect of the PCO2, and therefore we could argue that maybe there seems to be an apparent change in acidosis for the worse, but not the pH. Because it's really the pH that matters, isn't it? Okay, so what is the fuss about normal saline infusion? For the next 15 minutes or so, I'm going to talk about that. So this is a very interesting article. If you guys are interested in history of normal saline, this is actually fairly recent, from 2008. If you're interested in reading, you should read it, because they did a lot of work trying to find when normal saline was actually introduced into medical therapy. So in the 1800s, a young physician who had just graduated thought about this, through different paths. He went through thinking about oxygenation and so on and so forth, and came up with the idea of supporting the intravascular volume with a solution similar to normal saline. And then there were so many different concoctions that happened thereafter, and then people realized that patients were developing hyponatremia and dying and so on and so forth. So they weren't really helping with the salt solution, and different iterations of salt solutions took place. And then eventually somebody coined the term normal saline. What's normal about normal saline? Nothing, exactly. So it should really be called abnormal saline, right? Because it's not really normal. It's only 0.9% weight for volume. And it's normal to plasma for sodium concentration. That is the only part that's normal about normal saline. But it is abnormal to plasma for chloride, which is fine as long as you recognize that. It is the same as plasma for osmolality due to the explanation I gave you before. It's cheap, it's easy to make, and it maintains ECF volume in situations where we need to use it. So what's the big fuss? We have used it for over 100 years, close to 200 years. What's the big fuss? Normal saline infusion supports intravascular volume at a time when there's trauma, intraoperative needs, and so on. In critical care, we do have a problem. Because if you're going to focus on base excess as a marker of metabolic acidosis, and then you're going to say that this is associated with poor prognosis, fluid resuscitation, morbidity, and so on and so forth, without understanding the whole concept of what acidosis is all about, and if you're going to keep chasing the base excess, then it does become a problem. Because now you're going to keep on increasing the chloride in the blood, and you're going to artificially separate the chloride from the sodium. Therefore, there's going to be hypochloremic, so-called acidosis. Okay? So this question of what I started with, saying normal saline and metabolic acidosis, what does it really mean? There is a change in base excess, and there is a change in plasma bicarbonate concentration depending on how rapidly you infuse the child or adult with normal saline, and whether or not the kidneys are functioning. So there are so many caveats to this whole attitude of normal saline gives you acidosis. Then the second question is this true metabolic acidosis? What I mean by that is that what is it doing at a cellular level? Because that's what we are really worried about. Cellular dysfunction as a result of rapid changes in intracellular pH, that's what we are worried about. And then the next question is, does this require further fluid therapy? So we need to look for the etiology. So if you see base excess, or if you see high chloride level on a regular blood work, then you have to look to see, is this hypochloremic metabolic acidosis? Is there an anion gap? Is the anion gap increasing? If the anion gap is increasing, of course we're worried about ketones and lactate and so on and so forth. But if the anion gap is not increasing, what are we worried about? Why are we chasing this? However, there have been some questions about normal saline infusion and this resultant apparent metabolic acidosis being bad for other reasons. What are those reasons? So there have been some concerns with regards to GI tract function, renal function, coagulation, as well as immune system dysfunction. So let me take you through one at a time. So GI tract is absolutely controversial. So I'll just highlight a few articles here for you. So the first article, this came out in 1999. In volunteers, they took about, I think, 12 or 10 human volunteers and gave them normal saline as well as Ringer's lactate for a variety of reasons, and they were looking at urine flow rate and many other things. And it turned out that these patients had maybe a very slight increase in abdominal discomfort. Okay, so that started the whole path of, does normal saline cause abdominal issues? And then all of a sudden it was the metabolic acidosis as a result of normal saline that caused this abdominal discomfort. And therefore, people that undergo particularly abdominal surgery shouldn't be on normal saline. Okay, I have no shares in normal saline, by the way. Then this other article, I mean, there are tons and tons of articles that you can look at. I'm just highlighting a few. This other one looked at abdominal aortic aneurysm repair as an outcome study, and what they showed was that there may be, again, not a significant number, but there may be an increase in blood products need in those patients that were treated with normal saline as opposed to Ringer's lactate. Then another study came up, and they talked about discomfort with abdominal pain, nausea, vomiting, and all of those things. However, that seems to be more in relation to crystalloid versus colloid. So it had nothing to do with whether you hung the colloid in Ringer's lactate or in normal saline. As long as you had colloid, it seemed to be better in terms of all these symptoms. So you can see where I'm going with this. The literature is full of all these studies. No one is sure what is the right answer. And there seems to be a lot of association drawn, but I'm a mechanistic person, and if I don't see a reason for these things, then I'm looking at it saying, why? Is it the chloride, is it the sodium, or is it the so-called acidosis or the hydrogen production according to the Stewart theory? So GI tract, bottom line is there is no significant clinically relevant adverse effect in adult studies. Intraoperative crystalloid restriction may be considered based on the last study that I showed you, so that if a patient requires large volumes of IV fluid, you might not want to give them all as crystalloid. You might want to give some of them as colloid. What about the kidneys? There have been several studies that have looked at kidney function. And so when you compare normal saline infusion to Ringer's lactate or plasmolite and all kinds of different solutions, there was some impression that was created in the literature that you had decreased urine output, or the urine flow rate started to be slow in someone who's receiving normal saline compared to the others. But if you delve into the actual articles and look at the different reasons why the urine flow rate was slow or was delayed, you really couldn't find an answer for that because they didn't report it. Either they didn't report it or they didn't actually consider it. So is it the osmolality of the fluid that you're giving? What was the ECF volume to begin with? Did the patient get overexpanded, therefore they started to pee pretty quickly in some solutions versus the other? What are the different volumes? So all these questions have been unanswered, and somehow conclusions have been drawn that when you give normal saline to someone intraoperatively or immediately perioperatively, that they have delayed urine output, which is not true at all. However, recently a study was published. This group, Lobo's group from the UK, are very strong proponents of balanced solutions and also Stewart's theory. So they did a study, and they've done many, many studies, but this is the most recent one, that looked at actually whether there is a change in renal blood flow velocity after a patient is given, or volunteer is given normal saline versus plasmolite. And they showed that there is a slight decrease in renal blood flow velocity. And the theory behind that is that if you give a lot of chloride to someone, that chloride needs to be excreted. So the kidney is going to initially excrete that chloride, and that's going to be seen by the juxtamedullary apparatus in the kidney, which says, whoop, too much chloride, I'm going to shut the filtration down because I don't want to excrete it. That's called tubular-glomerular feedback, and that's normal. But that normal only works if somebody has got decreased ECF volume. So it all depends on what the sympathetic nervous system supply to the kidney is, what the kidney is reading from aldosterone, ADH, and angiotensin II, and many other hormones, and none of those have been looked at. So without those, you really couldn't say that the blood flow velocity going down was a good thing or a bad thing. These were human volunteers, probably in their lab. Right? They took 12 people and did the study. So I mean, how did they get through ethics if they thought that this was going to be a bad thing to do? So you have to take this kind of studies with a pinch of salt. I'm not saying that this is not real. All I'm saying is that when we look at all these things as supportive evidence that there's something horrible that normal saline does to our body or to our patients, we have to critically analyze the data and say, what is it that it's doing? What is the mechanism? Are all the data points entered into the study so that you can read it and understand it rather than draw the conclusions that the investigators have drawn, because maybe they are biased. What about coagulation? So that's always a worry in someone who's got a lot of fluid being given, particularly post-operative or intra. So there seems to be some indication that maybe patients who received normal saline require more platelet support. But this is not a significant difference. So there's a trend. So we don't know what the underlying etiology of the patients that required this more platelet transfusion. So it's not consistent across the literature. So the bottom line is there is no evidence for adverse effects. What about immune function? I mean, I can show you all this data, but I don't want to bore you. It's getting late. People are going to become sleepy. So I'm going to say, trust me, I have looked at it, and there is no consistent, significant effect. So I'm going to go back to the objective. So the objective was, one was to understand the impact of saline infusion on acid-base status in the blood. I hope I have taken you through that to tell you that there may be an apparent impact, but it largely depends on the amount of IV solution that you're using. So it could be dilutional partly. Partly it could be due to the Stewart theory of new hydrogen production. But whether or not it has an impact on cellular function, the jury is still out. I would say more than likely not, from what we know. And so now I'm going to go back to our first question and say normal saline infusion in large volume results in. Pick your answers, please. Great, excellent. So the whole idea is whether it's apparent or not, from our definition of acidosis, we would call it hyperchloremic metabolic acidosis. But the important point is, what is it due to? So pick your answers again. Oh, still got a few. That's all right. Can't be 100%. So it may be as a result of dilution, or it may be as a result of Stewart's theory of hydrogen dissociating from water. So now we are going to look at our baby again. So what's the acid-base disorder when he first presented? Okay. Great. Okay, so it's normal anion gap metabolic acidosis. I'm not sure why somebody chose increased anion gap, maybe because the anion gap is at the upper limit of normal, but regardless. All right, so now what is the acid-base disorder in this baby? So received 40 mL of normal saline. This was the initial value. This is the value after the bolus. Okay, great. So why do we not need the albumin level? I put that in there just to bring out a point, because in this patient, the anion gap is so low that you really don't need the albumin level. Okay? Because if the albumin level is 20 and the anion gap is 4, and if the albumin level is 40, the anion gap is going to be 9. right? Because you would increase it by 2.5 times for every 10 grams change. So the anion gap is still within normal limits. Therefore, this is still normal anion gap metabolic acidosis. Now, if you want to delve into it in more detail, you'll want to know what the albumin level is. So our take-home messages then are normal saline is isotonic to plasma from a sodium point of view, but there's nothing normal about it. It's easily available and it's cheap. Large volumes can give rise to metabolic acidosis, but the type of metabolic acidosis is hyperchloremic metabolic acidosis, and it does not appear to have any significant clinical adverse outcome. And when the base excess is negative, meaning that you need to, it appears as if there is so much acidosis that you have to give the patient something, look for a cause, because it has to be increased anion gap, without which you cannot assume that the patient has got high lactate or high ketones or any of those things. If there is an increase in the anion gap, then you look for unmeasured anions, as I said, lactate or ketones for the most part, and change to IV to more balanced solution in cases where you're not sure, and if you're managing a patient and lactate seems to be climbing and then it's dropping and you're not entirely clear about it, now you can use a balanced solution. People will argue that balanced solutions are more physiological, so why not we use it? The reason why I would suggest not going towards balanced solutions at the present time is really mainly cost. So according to my readings, and I was going to check up with our hospital accountant to find out how much it really costs, but it looks like as if it's about, normal saline is about 1/10 the cost of Plasma-Lyte. So when you're running liters and liters of solution for in the ICU and on the wards, it's not cost saving to do that. As long as you don't cause a problem to the patient, I think you can justify you continuing to use normal saline. The second thing is that I didn't talk to you about some of the concerns with regards to balanced solutions. So balanced solutions have got calcium and magnesium added to it and several other things added to it. And there have been some studies that have shown that patients have done poorly when they have compared normal saline or Ringer's lactate with Plasma-Lyte. And the reason behind that is maybe to do with magnesium and calcium that's added to the Plasma-Lyte. So everything is a balance, not just balanced solution. So when you see a patient, as always, nothing is in a protocol. It's not cookbook, otherwise we wouldn't be here practicing medicine and learning new things all the time, trying to evaluate ourselves critically all the time. So you look at the patient, you look at your data, look at the lab values, and then decide what would be the best suitable solution for that particular patient. With that, I shall close. Any questions? Questions from the other side? Okay. Yes, John.
So do you think that the argument with respect to sodium chloride IV administration is causing an association of protons to water applies to high salt diets? So individuals who are chronically consuming, like in Canada on average 3,400 milligrams per day, do you think they have a slight acidosis induced by this oral administration of sodium chloride?
That's quite interesting. That was one of my arguments against this whole thing. And I looked for it in the literature, and I can't really find anything that people have looked at. Maybe you should look at it. Because absolutely. So, you know, we consume so much sodium chloride, and most of the times we do consume sodium as chloride. You know, sometimes it's bicarbonate and other things. But for the most part, we do consume a lot of sodium chloride. And we don't see that. People are not running around with acidosis. And when, in the 70s, when Mitch Halperin did a study looking at what is the metabolic burden of metabolism, production of hydrogen ion, he looked at normal Western diet and found that most people produce about 1 millimole of hydrogen ion per kilogram body weight based on what they ate. So I had a chat with him to see, Mitch, did you look at the sodium chloride intake? And he said, you know, at that time there was no controversy, I never even looked. So we don't have data. So my intuition would be that probably not, but I can't say that for sure. Daniel?
Thanks for the talk. I don't know if I'm more confused now than I was before. But one issue is, obviously, as you said very well in the end, is you have to look at your patient. One thing is to give 1 unit, 10 per kilo of normoxidil on board. Another thing is giving 110 mLs per kilo in the PICU or in the emergency department. And we see this all the time, that they ended up with a quite significant metabolic acidosis. And then if you look, really pay attention to what's going on, then you start thinking, does the patient need more fluid? And the young, inexperienced person will need more fluid. And then you end up with complications. Or you ended up looking what are the causes of this metabolic acidosis. And the obvious in front of you is the chloride. So there's a recent study now in JAMA published about maybe 3 months ago from Australia and New Zealand consortium, looking at, it's not a very well designed study, and I don't know how they make it to JAMA because there's some big flaws there. But it raised the issue, and that's the issue that is being in the literature, is the excess chloride. So they studied, just for people that haven't read it, compare 2 time points in an ICU multi-center, and they look at using just whatever the doctor wants to use, that usually is high chloride solutions. And then the 6 months after a washout period, they decided to just go with balanced solutions. We call it Hartmann solutions.
Yeah, Hartmann.
Lactate and the plasmalites. And albumin, with poor salt albumin, was 20% versus our 5%. And they looked, and there was less dialysis need and less creatinine increase in the second group. It's not very well designed. It's a cohort study again and all that. But there is now a human, perhaps, when there's smoke, there's fire, perhaps confirmation that maybe chloride, for the reasons you mentioned, is a bit detrimental. And that's why we in the ICU, one of the reasons is we're trying to shy away with large amounts of fluid from normalcy. So when we start resuscitating someone in the ICU, we usually, thank God now, normal saline as opposed to albumin. I've never understood why this century is the most large amount of albumin I've seen in my life. We got buckets of vials of albumin every day being discarded. Now we're using normal saline, but when we start using 2 or 3, then we say, let's go for plasma. And that's the
Yeah, I agree. I totally agree. I mean, I didn't put up the JAMA study because there are many studies like that. And the JAMA study is interesting, as you said. I also felt the same way. I didn't know how it got into JAMA because I thought they were pretty stringent about methods and, how they did the study. And we didn't have baseline renal function on those patients, and we couldn't really compare the one before to the one after. So there were many issues related to that. So that's why I didn't bring that up. But there are a smattering of studies like that that have been done showing that perhaps giving someone Hartmann's or Plasmalite is better for outcome compared to normal saline. But none of them, from what I have scrutinized, have had good evidence to support it one way or another. There may be a trend, but I don't understand the mechanism, and they don't give the whole detail for us to really be able to look at the data. So there was a very nice commentary that came out, I think about a year ago or so. I can send it to you if you're interested, which talks about the pros and cons of all the different studies that have been done as well. Why?
When you say large volumes, what are we talking about?
Yeah, so as Daniel alluded to, in pediatrics, we don't really know what the large volumes are. But if you look at the adult literature, for the most part, large volumes are talking about almost 10 liters. So that's where they're beginning to see some changes, which we don't see in pediatrics. So when you see a patient in the emergency room, like the baby that I showed you about, really there was a little bit of increase in the chloride, and the baby is continuing to lose because it's got diarrhea, so continuing to lose bicarbonate. So if the bicarbonate drops a little bit, it may be dilutional, it may be because of this chloride effect, it may also be because they're losing bicarbonate. But this is not somebody that is going to need more and more fluid resuscitation, because that's the bottom line. That's what Daniel is talking about, is that when you see a baby and you look at it and you say, oh, base excess is such and such, and therefore I need to give more fluid, and you keep on giving more fluid, and that's detrimental, because more is not always better. Does that make sense?
This may be simplistic, but if a patient gets significantly large quantity of fluid, more than they need, is there a detrimental effect on cardiac muscle function, gas exchange in the lungs, and dilution of hemoglobin with oxygen delivery to the system? Wouldn't that combination contribute to a metabolic effect on the cells?
Sure, it's a possible, theoretical explanation, but can I say that from the literature whether people have looked at it? No. So there have been some studies in pediatrics as well as in adults looking at respiratory function and cardiac function, particularly after somebody has had cardiac bypass surgery and so on. But they haven't really come up with any correlation or association between any large volume of fluid and therefore its effect on cardiopulmonary function. So in terms of previous studies, we know that if somebody was wet, which is what the term that ICU uses, then their cardiopulmonary function is going to be poor. That's given for all solutions. But they haven't separated it out to say, okay, if somebody got Hartmann's versus Plasmolite versus Ringer's normal saline, would they have those changes more in one solution versus the other? No one has looked at it. But in my opinion, if you ask me for my opinion, in my opinion, I don't think so. And the reason being, if somebody is being ventilated, the PCO2 portion of it is being controlled with ventilation. And even if you believed in, and I do believe in Stewart's theory, that there is hydrogen dissociation and therefore there is some apparent acidosis, that doesn't produce more CO2. Just the same way as, if you look at Plasmolite, that doesn't produce more CO2. Ringer's lactate, on the other hand, has the potential to produce more CO2 because it's lactate, it's not acetate. And you put in lactate, well, first of all, the liver has to be functioning to be able to metabolize it. Otherwise, you're going to get lactate acidemia from the lactate that you're giving. Second thing is, when the lactate is metabolized, it produces more CO2 than when acetate is metabolized for the same amount of bicarbonate. So you could potentially have more CO2 production with Ringer's lactate, if anything.
Minor thing, just because of the audience here, some people travel to Africa and do some studies there. Everybody, and there's a clinic there. If you look at the New England Journal recently, saw that study in Africa with kids receiving fluid comparatively, and they ended up dying more than ones that get no fluid. So we have to be careful what you're dealing with. If you're dealing with malaria, which has an hemoglobin of 30, and you're giving more fluid, you're going to kill that patient. Yeah. And that's one of the things of that study that you really have to be careful not applying to our population here. It's a different population, so that patient needed blood. And the question is also, you see many anesthetists in our center sometimes using gelatin-based or
starch-based
solutions, and that is now really proven to be detrimental to the kidney, independent of quantities. So we're going to embark on that type of solution.
Thank you. Yes. You have to speak up. There's some. So that's an excellent question. I was hoping that somebody would ask me that question. So first of all, giving bicarbonate to someone is not innocuous. So if they needed the bicarbonate because they're losing it, yes, you do want to give it. If they are producing hydrogen at a rapid rate and they're not metabolizing whatever the organic anion that's coming with it, then you need to give it to protect the pH so that they don't have issues with myocardium. But as the endocrinologist will tell you, even in DKA, we don't give bicarbonate because bicarbonate has got quite a lot of adverse side effects, such as, when I was talking about the push and pull theory, what happens is that if the blood flow to the cells is not adequate, and you give this patient bicarbonate, they will now produce local CO2 such that you will increase the intracellular acidosis. So this is called paradoxical intracellular acidosis. And if that acidosis is going to be seen by the heart as well as the brain, then you have caused more harm trying to chase a number or a measurement that you have got which you're not even sure whether the acidosis is meaningful, and put this patient in dire danger. So you've got to again look at the patient and say, where is this hydrogen coming from? What's happening to the anion? Can the anion be metabolized? And if I gave more bicarbonate, am I going to cause more intracellular PCO2? Okay, if there are no more questions, we'll close this. Thank you.